you can get it started.
Good morning, everybody, and welcome to Department of Medicine Grand Rounds. I'm Clay Smith, the Division Chief for General Internal Medicine, and this morning I have the distinct pleasure of introducing to the department one of our former internal medicine residents, Dr. Justin Kingery. He earned his combined MD Ph.D. degree from UofL back in 2012, then spent 3 years here training with us. We were certain that Justin would go on to do great things, and we were not disappointed. Following residency, he moved to New York and was the first global health fellow at the Weill Cornell Medical College. He developed an interest in cardiovascular diseases in East Africa, and over the years has served as a mentor at Cornell, rotating through the school's Bugando Medical Center site in Tanzania. He is a prolific researcher and has served as the principal investigator on 2 NIH-K awards, as well as a collaborator on multiple R and D level awards. Just this year, he was selected as a finalist for the 2021 Weill Cornell Department of Medicine Young Investigator Award. In the time since he graduated from our program, he has matured as a clinician as well. He has served as an assistant professor of medicine in the section of hospital medicine and has been named the medical director of one of their step-down units. He also served as a lead physician in developing and attending in pop-up ICUs during the height of the COVID-19 crisis in New York. To those of you who already know Justin, please join me in welcoming him back home to Louisville. And for those of you who do not, prepare to be impressed. And with that, I will turn over to Dr. Kingery, whose talk is entitled Heart Failure in Low and Middle Income Countries, a Burgeoning Epidemic. Justin?
So first, Clay and everyone in Louisville, thanks for having me. It's absolutely outstanding to be back here. I left here 7 years ago, and really I feel like this is my home. So I'd love to express my appreciation for the Department of Medicine here for allowing me to highlight just a very small piece of the amazing work that both current and former UofL team members are doing all around the world every day. I remember sitting in the Grand Rounds lecture hall before COVID when I was both a student and a resident here at UofL, and thinking that I'd never even come close to doing the amazing work that those people were speaking on the stage were doing. And I'm still not sure that my work is even a small percentage as amazing, but it's an honor to be here and share some of it with you today. So before we get started, I should note that I'm funded by grants from the National Heart, Lung, Blood Institute, the Institute for Allergy and Infectious Diseases, and the Fogarty International Center at the NIH, and also Sandy Weill and the Weill Family Foundation in New York City. Since leaving Louisville in 2015, I've worked with the Cornell Center for Global Health, and we have teams in Tanzania, Haiti, India, and New York, and we've been characterizing cardiovascular disease in a broad sense, as well as the interactions of cardiovascular diseases with risk factors, the environment, infectious diseases, and other things as well. So our teams are amazing, and they work on very broad ranges of this topic. And so in this talk, I have more to share with you than we have time. So I've structured this as kind of a general overview of the current status of heart failure in the world, and specifically my research to give you kind of a sense of the scope and depth of the work that we do. We'll discuss our programs in Haiti and Tanzania, more specifically, the global burden and trends of heart failure around the world, and data from the ground itself. That said, before we get too deep into the research and epidemiology and things like that, I'd like to start maybe a bit differently than the usual Grand Rounds. Like I said, I was a resident here in internal medicine at UofL, and I began to realize during that time that my career path would probably involve academic hospital medicine and research and team building, and perhaps even outside the United States. That said, that path wasn't very clear to me. And it definitely wasn't as clear as it was for my colleagues in specialties such as cardiology, pulmonology, things that have fellowship and direct paths. And so I also have heard that we might have a few students interested in global health joining our call this morning. So this first section will be for you guys, people who don't know what that path might look like, but might be interested in this area. And this is one path, it's my path through global health. And so we'll deviate from the plan here just for a few slides and get a little off path. So how did I end up in global health? I started my life in the beautiful, but sometimes isolated mountains and the coal fields of southern West Virginia. And one of the most frequent questions I get in New York City is, how do you end up from there a world away in New York City? And even further, how do you go from New York City, this is Cornell Hospital where I work in the Upper East Side of Manhattan, to the area surrounding Lake Victoria and the Serengeti in Tanzania. The top picture on the right is our hospital in Tanzania. And also to the slums of Port-au-Prince, Haiti. And this picture on the bottom is right outside our clinic in Haiti. And so my path began a little bit weird. So my path to research in global health started in college. I can't be sure that I was born to do research or even born to do medicine for that matter. But that said, one evening I was in my dorm room over at Marshall University in West Virginia, and an advertisement came across the TV screen saying that NASA was interested in allowing college students to design and perform experiments aboard their astronaut training plane, also known as the Vomit Comet. Some of you may have heard. Here's a picture of it here. So my friends and I set out to find a project. We just wanted to get on that plane. We want to see what that was like. And so at that time, John Glenn, you see here a Time magazine article from around that time, he was headed back into space at an older age. And so while he was in space, he reported visual disturbances. And NASA was interested in exploring what happens to your eye when you're weightless. And they wanted to figure that out because if you're going to live in space, you need to know those things. And so we designed this little project with the help of our local ophthalmologist to test what happened to the eye, to test the pressure of the eye, the curvature of the eye, things like that when you're weightless. And we actually found that the pressure in your eye increases about 53% in the acute stages of weightlessness. And so while that was really interesting to us, we probably weren't changing the world. In fact, NASA scientists were working on this as well, and they were really just letting us do a project. Instead, I think the important part of this project and how it sparked the rest of my career was we realized that the world was starting to change us, that we were hooked on human health and inquiry and research ideas. And so I came to University of Louisville to chase those research ideas and that bug in 2003. And during that time, it was in the earlier days of some very exciting cardiology research here at UofL. I was working with Sumant Prabhu, who's now down in Alabama, and others who are still here, Dr. Steve Jones and Dr. Botniger. I was peripherally associated with their labs as well. And we were all starting to uncover these links between immunity, cardiovascular diseases, and what was really happening. And it was outstandingly exciting at that time. At the same time, I wanted to know more of what was happening out in the world. You know, cardioimmunology was really exciting to me, and it opened my mind to what was really happening in science in the world, or in our area. But was it only important to us here in Louisville or Kentucky, or was that important everywhere in the world? So around that time as well, I became friends with a well-known figure here in Louisville. Some of you know or have heard of Wesley Career. He's a great marathoner and was eventually a member of Kenyan Parliament. And he was here at UofL at the time. We became pretty good friends, and I began to go stay with him in Kenya and start to learn about what was happening, in the remote areas of Kenya, right on the Ugandan border. And throughout my time in residency, I stayed with him quite often. And so while there, I started to understand that cardiovascular diseases are not just diseases of my family in the coalfields of West Virginia or in Kentucky, but they're global issues. And so after internal medicine residency, I moved on to be a global health fellow at Cornell, and have worked with teams in Tanzania and Haiti to more clearly understand these problems on the global stage. And so that's kind of a path, hopefully, that'll help some of you students figure out, like, this is one way you can get here. So much of my work now and time is centered in sub-Saharan Africa, specifically in Tanzania. You can see on the left here, circled in red. And our teams more specifically work in the town of Mwanza, Tanzania, which is in the western part of Tanzania, not far from Rwanda and Burundi. You can see it's indicated by the star here. Mwanza is the second biggest city in Tanzania, where nearly 50% of the population lives on less than $2 a day. And to put the country in context for us, over the past decade, Tanzania has experienced multiple cholera epidemics due to population shifts. The recent death of a sitting president, perhaps from COVID, though we're not sure, which resulted in even further political instability. More specifically, within Mwanza, our work is centered at the Bugando Medical Center. It's a 950-bed teaching hospital, serves an area surrounding area of about 15 million people. It's one of 4 referral centers in our country, and so it takes care of about a quarter of the country. And here in the top right, you can see my colleague, Dr. Rob Peck, who I worked closely with on the ground there. teaching in our ICU, and that's where we do the majority of our clinical time when we're there on the ground. I also work in Port-au-Prince, Haiti, and so Haiti, as many of you probably know a little bit more about Haiti, is one of the poorest countries in the world, and about 60% of Haitians actually live in slums. And as I'm sure you've heard in the news, the struggles of everyday life in Haiti are daily. You know, the massive earthquake in 2010, the recent earthquake as well, multiple cholera epidemics, political instability, assassination of the president recently. These are difficult situations to work in, but these are places we need to understand health and humanity. So more specifically within Haiti, I work at the Cornell GHESKIO clinic. So GHESKIO stands for the Haitian Group for the Study of Kaposi Sarcoma and Opportunistic Infections, or at least the French version of that. And it was founded in 1983, and it's located in downtown Port-au-Prince, adjacent to some of the largest slum communities. And you can see it outlined by the blue box here. In fact, that used to be, GHESKIO clinic used to be on the water there, and the slums across the street, which you can see over here, actually were built upon landfill that was recently filled in. GHESKIO, interestingly, was the first AIDS clinic in the world. And over the past 30 years, their approach to public health to prevent and treat HIV has been phenomenal. It's led to a decrease in the national prevalence of HIV from 6% to 2%, has been at the forefront of HIV-focused research, really for the world. And in very recent years, they've started to understand that HIV is stabilizing, but that cardiovascular diseases are becoming the bigger issue, even in downtown Port-au-Prince. And so the clinic is transitioning the successes of HIV care into cardiovascular care. And so one of the things that we'll talk about today is how do you transition into that? So my specific interest in the cardiovascular disease umbrella is in heart failure. And so let's start with the good news in heart failure. So while there are approximately 64 million people living with heart failure around the world, which, by the way, represents an age-standardized prevalence of about 830 per 100,000 people. This prevalence decreased by 7.2% over the past 27, I'll say 30 years. So that's great. The prevalence of heart failure is decreasing. And as you can see on this map here in the bottom right, the lighter and bluer colors, so greens and blues, represent the greatest decreases in heart failure prevalence over that time. And the US and Europe are doing extraordinarily well. Now, the bad news. Unfortunately, this is not true for the rest of the world. Only 20% of the global population lives in those countries where we're improving. 80% live in low and middle income countries where the story's not the same. That 7% decrease that I mentioned is nearly entirely driven by improvements in one very specific region, and that's Western Europe, so Portugal, Spain, and those countries. So put simply, the heart failure prevalence and also the cost burden on the healthcare system of heart failure in LMICs, or low and middle income countries, is growing, and growing quickly in some areas. You can see here that Oman has the largest increase at nearly 26% increase. And as you can see also in the map, most countries in Africa have increased, so the oranges and the reds. And so things are not great for the rest of the world. We can't really pat ourselves on the back too much here in the US. So if we want to condense this down a bit to be a bit more digestible, we could look at the age-standardized years lived with disability from heart failure. And you can see that here on the y-axis. And we can look at that over the same time frame. And like I said, we can pat ourselves on the back here in our high-income setting in the U.S. You can see, we can see that the red line is showing that it's clearly improving. If you're outside that high-income setting, every other status is worsening. So even if you're high middle income status, if you're low income, all those countries are worsening throughout the world. So the largest prospective cohort, what's happening to those patients? So heart failure is growing throughout the world. It's pretty prevalent, but what happens to those patients over time? So the largest prospective cohort study to date, investigating the global one-year mortality associated with heart failure, was called the International Congestive Heart Failure Study, or INTER-CHF, we refer to. And this study enrolled both clinic and hospital-based patients over 16 countries. And while it was a heterogeneous population and has some limitations, for example, in Africa, Patients were enrolled from large, wealthy cities, and it also mixed hospital-based and clinic-based. It does provide us with our first important data from these parts of the world. And so in Africa, the one-year mortality of heart failure was strikingly 34%, and that's the highest in the world. So heart failure itself is also not a homogeneous diagnosis, and the patterns within it are changing as well. So historically, heart failure with reduced ejection fraction was reported as the most common subtype. However, at least in the US, sometime around 2012, or some people argue even before that, this changed, and heart failure with preserved ejection fraction became the most common and is now the most common subtype. Scarily, though, while the mortality of HFrEF is improving, the mortality associated with HFPEF, the most common type, is actually worsening, with some reports indicating it might have gotten 60% worse. That may be a little bit overblown, but nonetheless, it's worsening. And whether this same pattern is happening all around the world really remains unknown. We don't know much. So it's important to note that all that data I've mentioned is primarily based either on modeling studies from the Global Burden of Disease database or from these bigger studies in wealthier cities, even in the LMICs. And they may not or likely do not represent ground level information from these countries, so where the population really lives. And so the first heart failure study out of Tanzania, where I work, was conducted at the Capital Hospital in Muhimbili National Hospital, and enrolled 427 heart failure patients who presented to their medical clinic. And so strikingly, these patients were 10 years younger on average than those seen in high-income countries. So heart failure is happening in young people. And also, while ischemic heart disease is the most common etiology of heart failure in high-income settings, hypertensive disease is by far the most common in Tanzania, or at least was in this study. It was responsible for about 50% of all the failure. The one-year mortality was reported at about 20%. So in the range of that 34% seen in the INTER-CHF study. However, we should also note that 20% might be underreporting because this study, again, was in the richest city in Tanzania. So those patients might be a little skewed towards receiving disproportionate higher levels of care compared to the rest of the country. So what does it look like when you have to start figuring these things out? So that's one thing to say, this is what the world data is starting to point to. But now we have to go into the population and figure this out. And what does it look like when a team begins to talk about how to tackle that problem? You know, CVD and heart failure, these are big problems. And to repurpose existing facilities to figure this out and to assemble everything we need. And frankly, it looks like this. This is a real picture from our GHESKIO site in Haiti, in Port-au-Prince. And it looks like people sitting around, combining ideas, talking about what they've learned from the population along the way, learning from the ground, leading with care. And so this is a picture of our team. This is Dr. Pop on the right, who is the director of GHESKIO and the founder and one of the most famous HIV clinicians in the world, probably. And Dr. Fitzgerald in the blue behind the table, our director of global health. And this was in Haiti about 2015, right when I got to Cornell. And for the students and trainees on the call today, this is what global health looks like. We don't go in with a grand plan of this is how we're going to change the world or do this massive study. We sit in a room and try to figure these things out with people that know what they're doing. And so I just wanted you to see what it looks like from the beginning. So remember, at that time, we had amazing HIV clinic facilities in both Tanzania and Haiti, but we had to build for CVD. So on the left, you can see the early days of CVD clinic. This one was in Haiti, but they looked the same in Tanzania. We were trying to figure out how do you do this? How do you repurpose these clinics for CVD? Also, we had to build our capacity to even collect the data. So for me, specifically, to understand heart failure, you have to see what the heart is trying to tell you, mostly by ultrasound. And so I had learned cardiac ultrasound on mice and rabbits and pigs right here in Louisville over in the Baxter Building and the Cardiovascular Institutes many years before, and had continued to refine those abilities in humans as a resident and then further with our cardiologists at Cornell. And so that I could train those teams on the ground. And in the middle two photos here, you can see the early stages of that building. So the left middle photo is me in Port-au-Prince, and the right is Fabian Posiano, who is our echocardiographer in Tanzania. And also in these settings, sometimes patients aren't always able to get to you at a central clinic, and so you need a team of field workers to get to them. So you have to learn how to repurpose the clinics you have, but also move those clinics out into sometimes difficult areas. And so that's what we did. We floated. These are real pictures from our teams. Floated, sometimes climbed. That's a real picture of me in the middle there, nearly dying on a way up a mountain in Tanzania to do an echo. We walked. We listened to people in some of the most difficult areas in the world to get this data from the ground, to get real data, to understand people, and to work together. And so the first study we actually completed in Tanzania was a longitudinal cohort study of adults admitted to our hospital. Sometimes this is a hospital-based study, but it's best to start with the low-hanging fruit, and then I'll talk about the population data. So in total, in this study, we enrolled 558 patients. 145 of those were eventually adjudicated for heart failure. And in that study, we aimed to determine the 1-year post-hospital mortality and the predictors of that mortality in people with failure. And so we found that about 15% of all of our admissions to our hospital were from heart failure. That's fairly striking just on its own. That patients, again, were very young. They were on average about 1 to 2 decades younger than expected. Compared to high-income countries. And we confirmed that hypertensive heart disease was, in fact, the most common etiology. So just like was seen in the richer city in Tanzania, it was also happening in our area in Western Tanzania. Very strikingly, we found that the 1-year mortality was about 60%. So a 60% chance of death in the first year after leaving the hospital after staying with heart failure. And these mortality curves here show that was even worse in people with renal dysfunction. So it was the strongest factor associated with mortality. So I'll keep this list as we go of what do we know, what have we learned? Because sometimes in global health, you just have to keep a list and jot these things down. Or what have I learned? And so the first thing we learned was that we confirmed that heart failure is, in fact, a problem in Tanzania, and it's associated with extraordinarily high mortality in populations outside the city. So we're starting to kind of drill down into the population. But what's happening outside our referral center? We're still one of 4 referral centers, so we may still be a biased sample. And so to start to answer this, we conducted a study at a regional hospital, so the next level down in our healthcare system, where we enrolled eventually 116 people with adjudicated heart failure. And the objective of this, again, was to just see what's happening with heart failure, so the prevalence, the subtypes, those kinds of things. And of note, I should say that one of your current UofL medicine residents, Nicole, has been helping me with this data. And so, again, for the residents and students, it's never too early. If you're interested in this, contact me now, and we can get you involved. But we found through this study that heart failure was responsible for about 10% of admissions. Again, we're always in that 10 to 20% range. So a lot of the people coming to the hospital have heart failure. And importantly, we found the new data that HFPEF is actually the most common etiology. Remember that up until this point, with TAHEF and other studies out of East Africa, HEF or REF had still been reported as the most common. And so we're now reporting that the same transition that happened in the US, maybe around 2012, has happened in Tanzania as well. Interestingly, also, we found that that patients describe their heart failure symptomatology differently than patients here in the U.S. do. So on this graph here, you can see the percent of patients complaining of malaise or volume overload, and I defined volume overload as dyspnea or edema. And while nearly half, you can see here, while nearly half of all the HFpEF patients reported malaise or fatigue, tiredness, only 18% reported dyspnea as the primary complaint. So we learned a very important global health lesson from this. So it's one thing to report percentages and data like that, but you also have to understand what the numbers are telling you from a community perspective. And the lesson we learned was that culture and the ways populations describe their health differ dramatically around the world. So what have we added to our list? We added that HFpEF is possibly now the most common heart failure subtype in Tanzania, at least in our region or at least in our hospitals. So around that same time, Dr. Molly McNary, who was a global health person who's who works with us and was trained at Harvard with Paul Farmer, and then came down to lead a lot of our global health work at Cornell and in Haiti. So I was working with her, and we were starting this Haiti cohort study. So this is the Caribbean's first population-based longitudinal CVD cohort, and we've enrolled 3,000 Haitian adults who are currently being followed over about 4 years, so 42 months, and we're about halfway through that now. And so hopefully you can see the theme of today. We're starting from that high-level global burden of disease level database. We're driving down to kind of national level data. We're driving down to a referral center, down to lower than referral center, and now we're down into the community. What's actually happening into the community all around the world. So the key thing about this population is that it is truly population-based. So up to this point, we and everybody else in the world, from a heart failure perspective at least, we're relying on that governmental level data and data from hospitals and clinics. But population-based means that our sample is selected randomly, and it truly reflects the population, as each person in our study is actually weighted for the population denominator. So we work with GIS mapping experts from different institutions around the world, and they help us find GIS locations within Port-au-Prince. They give us coordinates, and we go there and ask people if they want to enroll in the study. So they're truly population-based and representative. So this type of study, as you can imagine, is very challenging, and it involves pretty intense field work, but the outcomes are much more telling about what's happening in a population than a convenience sample or a clinic-based sample or a hospital-based sample. So this is the exciting thing about the Haitian study. It's the first population like this ever in the Caribbean. So from this study, with the help of one of my current mentees, Nick Roberts, who actually worked for the Global Burden of Disease group for 3 years, and is now a med student working with me at Cornell, we were able to determine that the age-standardized community prevalence of heart failure in Haiti is about 3.2%. That's much higher than the typical 1 or maybe even 2% reported in high-income countries, to maybe as high as 3 times higher. We also found that HFPEF is threefold more common than HFrEF in Haiti. And again, we're seeing these common themes around the world that matches Tanzania, and it matches what happened in the US some years back. But most worrisome, we found that heart failure begins at an early age. Again, we're seeing this all around the world. We're starting to understand better. With the first jump, you can see right here, first jump in heart failure prevalence being in the 40s. And that's 1, 2, maybe even 3 decades earlier than the US. In fact, the majority of patients in our study, you see 72%, were under the age of 65. And that is the age cutoff that's responsible for most of the heart failure in the US. In fact, only 20% of heart failure cases in the US are reported under 65. And so this is a disease of the young. Again, matching our Tanzania data, hypertension was responsible for most of that disease. And on a sub-point, a little glimmer of hope here, while only 43% of our patients had been previously diagnosed with heart failure, the ones with heart failure, 70% of them were on appropriate therapy. So that might imply that interventions targeted at the diagnosis rather than the intervention on heart failure may have the greatest impact in these settings. And that's especially important in the settings without the resource for these multi-pronged, very expensive attacks on heart failure. So you have to decide where to use your money in these settings. The diagnosis step may be the most cost-effective. So what have we added to our list of what we know? We've learned from this study that HFpEF is very common in the Haitian community. It's associated with obesity, hypertension, poverty, things like that. But, you know, it's one thing to say this is how much is out there, but what's driving it? We have to figure out, you know, what's underlying it. And so we'll turn attention there a little bit. So LMICs have a significant burden of some social and environmental factors linked both to heart failure and its precursors. And I know here at UofL, you have a fairly new division of environmental medicine, and you don't need me to tell you this, but you're very timely, because these issues we're starting to understand more and more every day. They matter, and they're on a larger scale than we previously realized. So, for example, people in LMICs have very high serum lead levels, at least in Haiti. We're starting to understand this, some parts of Africa as well. And it's likely from the use of car batteries that they turn into cooking pots, and so the lead leaks into the food. In fact, we have an upcoming manuscript in the journal Hypertension that correlates very high serum lead levels to hypertension. in our Haiti cohort, even after controlling for all other known factors. Food insecurity and mental health and stressors are all also very important drivers of disease, specifically relevant to these settings as well. So studies are important, and we have to know what's going on, but they're not enough. The mom with hypertension in a Port-au-Prince slum doesn't care about your study. She doesn't care about my study. She cares about staying alive for her children. And so we've also emphasized our partnerships at the national level to affect real change on the guidelines and treatments of the populations. And so here you can see our inaugural national CVD conference in Haiti. It was in 2019, at which time we were working with the Haitian Society of Cardiology and the Ministry of Health, and other places you see listed here, to integrate the knowledge that we were gaining into the first Haitian national guidelines for CVD. And this included really some giants of the field. You can see here in the front, that's Suzanne Operil from UAB, who was the chair of JNC8, and these are most of the actual cardiologists in the country of Haiti, and Ken Jamerson from Michigan, some big names in the field. And it was really an amazing time to see that the data that we were creating is starting to be used for the population. You can see me in the back on the right there, buried behind all those giants in the field, but that's where I belong. That was exciting. So we should always remember, though, that cardiovascular diseases and heart failure don't exist in a vacuum. So this top map shows the global prevalence of cardiovascular diseases, with red being higher prevalence. And the bottom shows the global HIV prevalence, with red again being higher prevalence. And so you can clearly see that there are overlapping epidemics here. So HIV infection, for example, is associated with an increased cardiovascular risk across the board, from a twofold risk in MI, stroke, and heart failure, to possibly a fourfold increased risk of sudden cardiac death, although as of yesterday, that's been questioned. New study was released. It's also important to note that HIV is associated with increases in hypertension, so an important risk factor for heart failure. So within our cohorts, two of my other mentees, Dr. GHESKIO from Tanzania, you see here, and Carl Rice, who's now a med student up at Columbia, led a project showing that HIV infection was associated with a significantly increased blood pressure in the first 2 years after starting antiretroviral therapy. And there are many proposed mechanisms for how HIV increases the risk of heart failure and other CVDs. And those include persistent immune dysregulation, vascular stiffness, direct cellular damage, and you can see on and on and on in these charts, ultimately all leading to heart failure and other CVD outcomes. So at our site in Tanzania, Dr. Peck, who I mentioned in earlier slides, and I, around that same time, started to see that these were overlapping epidemics, and we had to start figuring this out to start, number one, helping specific populations, so HIV populations, and also to maybe use those populations to figure out pathways of disease. And so we now have an ongoing cardiovascular disease cohort there that we have been following, in which we've been following about 1,000 people, so 500 people living with HIV and 500 uninfected. And we've been following them for 2 years on average, some people up to 4 years. So on these people, we collect echocardiograms, EKGs, measures of vascular stiffness, biobank samples, CVD questionnaires and measures, et cetera, et cetera, et cetera. So to truly impact heart failure, it may be too late in a low and middle income country when a person presents to the hospital with heart failure to really impact that care. And so we have to understand the precursors of disease. And so as we've learned, HFPEF is the most common heart failure subtype now. And diastolic dysfunction, or inappropriate relaxation of the heart without failure, is a very important precursor to HFPEF. And one of your own residents here at UofL, another one, in addition to Nicole, Deep, has been working with me to crunch some of this data, what's happening in the precursor to failure stage. And we reported in JID recently that HIV is associated with about a 2.7-fold increased risk of diastolic dysfunction. So again, the precursor to HFpEF at the time of diagnosis. And it's also associated with more severe dysfunction. And a common theme that we see continues even here, even in the precursor. that dysfunction happens at earlier ages than expected. So you see here in the 40 to 50 age range, about 20% of people with HIV have that dysfunction, and that's impressive. And additionally, we measured serum markers, a serum marker of myocardial dysfunction and immune activation. So it's called ST2, and it was significantly associated with diastolic dysfunction in people with HIV. So you can see here on the y-axis in this graph, this is the serum marker of that this is the serum concentration of that immune marker. And here are the HIV-infected people without dysfunction and with, and it's clearly higher. So what have we learned? We've added to our list of what we've learned that HIV increases the prevalence of the HFPEF precursor, diastolic dysfunction, and it may be associated with deranged immunity. At least there's some association there. So this is the last part of this I'll go through for the last couple minutes here is some very exciting data. I'm very excited about this that we're generating right now and I'm about to report. And so we have to remember, like I said, CVD and heart failure don't exist in a vacuum. They exist with HIV well, but HIV also doesn't exist in a vacuum. For example, these maps show the overlap of HIV and Helminth infection. So in this case, schistosomiasis. And as you can see at our site in Tanzania, there's a high prevalence of both of those diseases as well. So we have converging epidemics of three things now: HIV, schisto, and heart failure or CVD. So the schisto rate in our community is as high as 50%, and it's attributed directly to fishing activities and activities of daily life where schisto is endemic in the lake. So infection with schisto, I should say, leads to long-term negative outcome. For example, it's the leading cause of liver disease and upper GI bleeding in our region. This picture actually was taken by our study staff and shows the daily routine of the fishermen in the area. And you can see the exposures are constant to the water and to the schisto worms. Interestingly, though, animal studies indicate that acute infection with schisto may be cardioprotective. So that's incredible. For example, in this image that you can see here, this is an aortic cross-section from a mouse model that was fed a high-fat diet. And you can see a significant plaque burden outlined by the red box here in panel A. But in panel B, the same mouse model, but schisto-infected, so high-fat diet, but with schisto, has very little plaque. And further studies after this indicated that this vascular protection may be secondary to anti-inflammatory shift, if you'll allow me to use broad terms. So maybe shifts in monocyte macrophage phenotypes to M2 varieties, cytokine switches to the Th2 varieties. And so it kind of spurred a very interesting idea. And so there are natural questions here. So those questions are, does that cardioprotective effect of schisto infection observed in these animal models translate to humans? And even further, could that counteract the detrimental effects that we're seeing with HIV? And if so, could those competing interests, so pro and anti-inflammatory processes, lead us to novel pathways for cardiovascular disease, for heart failure or vascular disease, even for the general population? And so within that Tanzania cohort that I've been talking about, we designed a study to investigate this, the relationship between schisto and HIV and cardiovascular disease through testing for biobank samples and things like that. So you can see our objectives of that study, and they were to compare the prevalences of hypertension and diastolic dysfunction and lipid patterns. Those are the things we were interested in at the time. And to compare what happens in blood pressure over time. Like I said, we've been following these people over time, and to see what the interaction of HIV was in those models. So among the 1,000 study participants that we have, 50% had HIV active schisto infection. You can see 503 people here. And this table depicts the prevalence of diastolic dysfunction by schisto serostatus. So I showed you HIV before. HIV increases diastolic dysfunction. So this is by schisto status. And you can clearly see that schisto infection is associated with about a 40% reduction in the prevalence of dysfunction. So from 13.4% down to 8.1%. And that's very significant. So while that's scientifically fascinating, we have to remember that we do studies in the context of populations. Again, they have to matter for that mom in Port-au-Prince, right? And so does this matter for the population? And I would say it does, because studies indicate that about 25% of people with moderate to severe diastolic dysfunction will actually progress to heart failure within 6 years. And so this 40% reduction may have a very significant population effect. Notably, though, when we stratify this by HIV status as well, so Schisto and HIV, this improvement in function, in heart function, was only significant in HIV-infected group. So it was dependent on that pro-inflammatory HIV drive, and it wasn't true for the uninfected group. And I'll try to tie all this together in a few seconds. So mirroring some previously published data, we're also seeing that Schisto infection imparts a significant improvement in lipid profile. So most notably, Schisto-infected adults have a very significant reduction in the total to HDL ratio, you can see here. And that ratio is also known as the atherogenic index. Most of you probably heard of this, where higher values impart higher risk of atherosclerosis. And as was the case with heart function, this effect was limited to HIV-infected participants. And again, this is clinically important. Because studies tell us that a reduction in this atherogenic index of about 0.5 units could impart as much as maybe a 9 to 10% cardiovascular risk reduction. So you can see here that in our uninfected population, that number is about 2.3. It decreases about 0.4 units. And so you can see that we may get as much as an 8 to 10% cardiovascular risk reduction with that improvement. And so that's very interesting. The beneficial effects of Schisto are not limited to heart function and lipids, though. We also saw that it's associated with about a 15% reduction in the prevalence of hypertension. So in contrast to lipids and heart function, though, this beneficial effect on blood pressure was actually only seen in the uninfected group. And so that's an interesting thing. Why are the effects of Schisto on heart function and lipids only in pro-inflammatory, seen in pro-inflammatory drive, but that's not the case with hypertension, and hopefully we can tie that together. So while prevalence is important and it's intriguing, even more exciting is the finding of what happens over time. And so this graph depicts the change in systolic pressure over the first 2 years. And as you can see on the left, the Schisto uninfected participants had an average increase in blood pressure of about 3 to 3.5 millimeters of mercury over 2 years of follow-up. Whereas the infected group, shown on the right graph here, had very little change. And so what we're seeing is that the Schisto infection not only suppresses the prevalence of hypertension at baseline, but it seems to sustain that response over many years. So, as was the case with hypertension prevalence, this was limited. This overtime effect was limited to the uninfected group. And in this table, you can see that the blood pressure effects that I'm talking about were significant at both 1 and 2 years of follow-up, so all along the way. And while no time points were significant in HIV-infected group, we did see a pretty strong trend towards significance at the 2-year time point. And I'll talk just in a second about what that might mean for us. Again, we're just doing these studies to give us hints at what really is going on. And again, these are clinically important for our patients. Studies have to matter for the patient. And so studies indicate, very large studies indicate that as little as a 2 millimeter reduction in systolic pressure may impart as much as a 10 to 15% cardiovascular risk reduction. And we saw about a 3.5 millimeter of mercury decrease. So in summary from this section, I think very exciting section, this data shows that Schisto infection is associated with a 40% decrease in diastolic dysfunction, a 12% beneficial decrease in the total to HDL cholesterol ratio, and about a 12% absolute decrease in prevalent hypertension. And further, that suppressive effect of Schisto remains over time on blood pressure. And as mentioned, these are clinically important. And if we want to put that in a grander context, these are on the order of magnitude of improvement seen with the currently recommended exercise guidelines. So this is I'll tell you straight off the bat that this is a stretch. This is kind of in my own mind. What is my mind thinking at the moment? Where might this lead us? And this is not set in stone. This is kind of where is my research going. So the patterns that we're seeing might give us insight into the pathophysiology of cardiovascular diseases. And so we know, you see over here, that Dept and I showed that HIV increases diastolic dysfunction. And it's well known that HIV increases dyslipidemia. However, it's possible that those are counterbalanced. We know also some studies tell us that at least the diastolic dysfunction may be very dependent on monocyte phenotype. And so it's possible that Schisto infection may switch that monocyte phenotype and impart its benefits that way. And that said, the T cell dependent increase in blood pressure, again, studies are starting to show that T cells and maybe even eosinophils and other cells are important for blood pressure. Both at baseline and over time, may be blocked by the HIV-induced dysfunction of the T cells. So the suppressive effect of that Schisto infection would only be evident in the HIV-uninfected group because it's not possible in HIV-infected groups who don't have functional T cells. In fact, that finding that I mentioned briefly, that there's a strong trend towards a lower blood pressure even in the HIV-infected group after 2 years, presumably when the T cells have repopulated and recovered after ART initiation. Might lend even more credibility to that theory. So in short, obviously you don't need to remember this. I think what I'm trying to say is that these patterns may imply that activation of anti-inflammatory pathways are very important and maybe even necessary for these effects and may give us some insight into pathways of the disease. So what have we added to our list? We're coming to the end here. So we've added that some communicable diseases can give us insight into pathways of protection or maybe even treatment targets. I don't know. So if you'll allow me to be super grandiose for a second, could that lead us to one of the first HFPEF specific treatments? As many of you know, we have very few, if any, treatments for HFPEF. And so could these pathways exploiting these pro and anti-inflammatory counterbalances in nature help us figure that out? We got a long way to go, and maybe I'll never get there. But this is science, and this is the excitement. So in summary, I'll leave you with this. I think that CVD research in global settings, it requires truly a community. From epidemiologists to basic scientists to clinical trialists to implementation scientists to med students to internal medicine residents to field workers, and you can imagine on and on and on. And hopefully you've seen through this talk. With specific regard to heart failure, the prevalence is growing for most of the world. We shouldn't rest on our laurels here in the US at the data we're producing. That data is not true for the rest of the world. And we need to work harder to figure that out. But there are glimmers of hope. I hope that you've seen through some of the stuff that we've done. I've also learned and hope to impart here today that global health requires extraordinary teamwork, resilience, creativity, optimism. And more importantly, what I wanted to say, because this is maybe one of the only times I'll have the stage in Louisville, is that these are the things I learned right here in Louisville, at the med school, specifically in the residency program here. And so I think that that's important to note. And the opportunities for collaboration in these areas are endless. If any of you guys want to talk about any of this stuff, I'm more than happy to talk at length anytime. You can call, email, whatever. And so no good science leads only to answers, but I think mostly to further questions. And so I'll leave you with another question. And so I would say, is it possible that, in the middle of Tanzania, on the shores of a lake like Victoria, with its devastating combination of worm infections, HIV infections, or even in the slums of Port-au-Prince, Haiti, that we can uncover mechanisms that may challenge the concept of cardiovascular treatment and maybe even cardiovascular immunity? Maybe or maybe not. Maybe, again, I'm getting too grandiose. But I think that one of the reasons that I'm proud to work as an academic internist is that we're allowed to ask these crazy questions. We're positioned upstream in the process to see these crazy questions, both here and around the world. And so for the students and the residents on the call, I, again, want to leave with saying that Louisville is preparing you for this, and the rest of the world needs you to do this. And I can tell you with certainty that Louisville is preparing you for this because that's what they did for me. And so, again, it's honestly been an honor to be here, and I'm happy to try to field any questions that anyone would have.
Thank you, Dr. Kingery, for your talk. I think you've definitely, hopefully, inspired some of our residents to go on and do great things, just like you've done. We do have a tradition of sending our Grand Round speakers who come to us from other institutions home with a souvenir from Louisville. So this should look familiar to you, Justin, if you look at Jason's green. He's got a Louisville slugger bat that will be greeting you back in New York.
That's great.
Hopefully coming back here someday in the near future. So there are some questions popping up in the chat, so I'll go ahead and read some of those to you. This is from Dr. Kalra, and he said, in many developing countries, increased heart failure prevalence is driven by diabetes, obesity, and hypertension. Culprits, does your data in Africa show a similar pattern, or is it skewed in extreme poverty in places like Haiti and Tanzania?
Yeah, so I think that the rest of the world is not immune from the effects of diabetes, obesity, things like that. And those things definitely pop up in all the models we have. So all the studies we have in Tanzania, all the studies we have in Haiti show that, as well as the INTER-CHF study has shown that as well. That being said, there are novel risk factors there. And so extreme poverty, for example, is a novel risk factor of these countries, which persists in multivariable models, controlling for all those things that you mentioned from high-income countries, so obesity and things like that. And then also, like I mentioned, there are other environmental factors. So environmental exposures that may be novel. For example, people in sub-Saharan Africa and Haiti and many LMICs cook indoors, right? And so there's an extraordinary particulate matter exposure, and there's some evidence that that might also worsen disease. So I would say that it's a terrible combination. So it's a combination of all those risk factors you mentioned from high-income countries with the addition of many more.
Dr. Krishnan from VA asked, was obesity considered a confounding factor when looking at the schisto and hypertension group?
Yeah, so we control those models for many things. Luckily, that CVD cohort, has pretty robust background information, and so we controlled for age, sex, obesity, the normal known factors. In addition to that, in settings like Tanzania, you have to understand the population as well. So, for example, schisto status in Tanzania may very well just be a surrogate marker for physical activity. So in order to get to the lake and be there doing your daily activity, it may just be that you are more physically active. And so that's why you have lower disease as well. And so we've run our models for many physical activity factors and dozens of others as well. And this is definitely still an independent marker.
I think you might have already addressed this, but Dr. May asked any information on treating obesity and the effect of that treatment on heart failure with preserved ejection fraction.
I don't know. I haven't gotten, to be honest, I think that the rest of the world has been left behind. We're far behind behind the US and Europe in understanding heart failure at baseline. For example, how much is there? A lot of our work over the last 5 to 10 years has been how much heart failure is there and what does it look like? And so we haven't even gotten to the point of interventional trials yet of how do we treat obesity and see what happens, whatever. And we don't know if that will behave the same as it will in the US and Europe. We just don't know that information yet. I'm well aware of the obesity paradox in heart failure in high-income countries, and I'm very interested in chasing that in low-income countries as well. Whereas we know that patients, at least here in the U.S., diagnosed with heart failure who are more obese actually seem to do better and have better long-term outcomes. We don't know if that's true in low-income countries yet, but we're very interested in chasing it.
Right, we are coming up on 9 o'clock, and I do not see any other questions in the chat. So, again, I wanted to thank you, Justin, for coming back to Louisville and telling us what you've been up to. We appreciate it.
Thanks so much. It's been absolutely a pleasure to be here.
Thank you, Dr. Smith, for making the invitation, and thank you, Dr. Kingery. It was outstanding.
Thanks. Thanks, Jason.
And just remind everybody, we will be back again next week, 8 o'clock Thursday. Gastroenterology will be presenting. I believe Dr. Nathan Liu will be the speaker. So we'll have more information out to everybody about that shortly. So again, thank you everybody for joining us, and we're off to a great start with Grand Rounds this year. And again, thank you, Dr. Kingery, for an outstanding presentation. And that'll wrap it up. We'll see everybody next week.